Welcome to Grand Rounds for those in person and those remotely. Just wanted to make a land acknowledgement that we're gathered and grateful to live and work on the unceded territories of the Salish people. Today's presenter is Dr. Thomas Hahn, a member of the Division of Rheumatology, and he's going to be presenting an update on giant cell arteritis. For some of you, it'll be a new date, but others it will be an update. Looking forward to it. Thomas.
Thanks so much, Dr. Casson. So we're going to be chatting about GCA today. Thanks, Dr. Casson, for the land acknowledgement. I have no disclosures yet. I'm actively working on it, so stick with me. The objectives today. So basically, excuse me, we're going to go over a quick overview of the pathogenesis and epidemiology of GCA. We're going to chat a little bit about what you guys will be seeing in your clinics and on the wards in terms of how these patients present. We'll dig into the latest and greatest in terms of how we're diagnosing GCA and then get into management. And with management, I'm going to give kind of an overview of the evidence, why we use the medicines we use, and then synthesize it with kind of an algorithm that we use locally with our vasculitis group to hopefully make it a little more logical as to why we do the things that we do. This is our obligatory Chapel Hill conference criteria slide, which basically just divides our vasculitides into large, medium, and small vessel, with the focus of today being giant cell arteritis, which is a large vessel vasculitis, with the understanding that there can be some overlap. So large into medium, medium into either large or small, and small into medium most commonly. Now, why is GCA large vessel vasculitis? This looks dangerously close to a pathology immunology slide, but I'm going to address it as straightforward, I hope, as possible. The real root of why large vessel vasculitis affects large vessels has to do with these small vessels in the adventitia called the vasa vasorum. Essentially, these small vessels, which exist in the outer portion of aorta and the major branches, bring some ligands or some essential kind of triggers that activate our immature dendritic cells that live within the wall. Those lead to recruitment of more dendritic cells, as well as activation of T cells. And from the slide, you can appreciate there's two T cell pathways. There's the IL-6 into T helper cell 17, which creates this IL-17, which is really the hyperinflammatory cytokine and pathway in GCA. So these are the fevers, the high CRP, the constitutional symptoms. The other aspect is these T1 helper cells, which is the more insidious kind of smoldering migration of vascular smooth muscle cells and myofibroblasts into the intima. That leads to the remodeling and can lead to a lot of the stenosis, some of the ectasia that we can get with this condition. And steroids, which are the mainstay of treatment, are very effective at turning off the hyperinflammatory picture, which is why these patients often improve quickly with high-dose steroid. But we are not as effective at turning off the T1 cells, which essentially can lead to gradual smoldering, delayed damage over time. Who's getting this condition? So this was a study done by Janet Pope, prominent rheumatologist in Ontario. In patients over 50 years old, there's about 25 new cases per 100,000. That increases to 50 to 65 when you gate for greater than 70, which just is a testament to the average age of this condition being about 73, 74. So this is really seen in older adults. And as age increases, that is a risk factor for developing this condition. There's about a 2 to 3 times predominance in women to men. And in the lower mainland, we're probably seeing about 400 cases per year, so about 7 per week. And lifetime risk estimated about 0.5% for GCA and maybe about 2.5% for PMR. Now, these are the 1990 classification criteria. You can appreciate that these really focused with headache, temporal artery changes on exam, and abnormal biopsy. This was really focused on the cranial aspect of GCA, which I'd really like to classify or clarify that these are not diagnostic criteria. So if a 50-year-old gentleman appears at your clinic with a new headache, a normal CRP, some tenderness at the temples, and a negative biopsy, would you diagnose them with GCA? No, these are for research purposes. So just keep that in mind. It's similar with like our ACR lupus criteria. They are research tools and they can be helpful, but they're not diagnostic. It all comes down to your clinical assessment. Now, we've had a recent update. So 2022 Joint ACR EULAR put out these new classification criteria. Specifically, this applies to individuals where a diagnosis of vasculitis has already been made, and when we have basically excluded common mimics, infection, and so on. The absolute requirement is that they have to be 50 and older. We really don't think that GCA really exists under the age of 50. And you'll see that there's been the addition of morning stiffness in the shoulder and neck. There's been certainly the ongoing temporal changes. But I'd just highlight that on this criteria, it's ultrasound that actually carries the highest diagnostic yield. It is equivalent with a positive temporal artery biopsy. And it's also able to screen for bilateral axillary involvement. So just kind of highlighting the trend in GCA diagnosis, really highlighting the importance of ultrasound. Now, this is just a nice tidy slide in terms of some of the clinical domains that we can see with these patients presenting. Certainly the vascular headache, scalp tenderness, jaw claudication, limb claudication, some of the PMR features of kind of proximal predominant neck, shoulder, hip stiffness, worse with movement, often worse in the morning, some constitutional symptoms, and then visual manifestations. So these are some of the findings that your ophthalmologist may have on their assessment, with AION being far and away the most common manifestation. But really, what are the symptoms these people are going to have? Diplopia, persistent diplopia, transient vision loss, so that amaurosis fugax pattern of the gray curtain descending over one's eye. These are what these patients are going to be presenting with. And so that is a high index of suspicion, and certainly would prompt kind of empiric treatment with us working to confirm the diagnosis. Now, what is our differential? So certainly non-arteritic AION, very commonly, we get many consults with AION, and it's our job to try to rule out an inflammatory component. But other things certainly include, there's some primary headache disorders, TMJ dysfunction, infectious concerns, malignancy, definitely we're mindful of. And then I just highlight carotid vertebral dissection. So for these patients coming from the eMERGE, that baseline CTA arch to vertex is hugely important to rule out a very common potential mimic of this condition. So definitely if you're getting these consults put to you, you'd be very justified in ensuring that there's a CTA arch to vertex in place. Now, large vessel GCA. So this is kind of a phenotype that we're increasingly aware of. There's large vessel involvement, which predominantly is the aorta and its major branches, which this 2020 study basically tried to take a great deal of TAC and GCA patients and put them into different clusters. And this cluster 6 is probably the most representative. Axillary involvement is present in about 98% of patients with large vessel disease. And about 40% of these patients have a negative cranial ultrasound and about 50% a negative biopsy. So we really do have to look for this involvement, and certainly CT angiogram is an important initial step that will commonly involve, if not vascular ultrasound. These patients are often younger. They'll often have a longer duration of symptoms by the time you see them, just given they're not as classic kind of headache, jaw claudication, and more constitutional symptoms is common. They're at higher risk of relapse. So we have a lower threshold for things like adding a DMARD along with your prednisone. Certainly, they can go along with a longer treatment duration. Thankfully, they're at a lower risk for vision loss. Now, how are we evaluating these patients? So there are no specific biomarkers for GCA, so we're looking for inflammation. Positive markers, CRP, ESR, certainly, platelets, ferritin, fibrinogen, an inflammatory pattern, SPEP, complement elevation, and things like anemia and hypoalbuminemia. Now, I'll just highlight, much to my chagrin, the sensitivity for ESR and CRP are only about 85. So there are CRP negative patients out there. They are the minority, but we can't get lazy when we see that negative CRP, as we can be surprised. Now, this is an inflamed temporal artery biopsy. You can appreciate, let me get a laser pointer. So there's lots of intimal proliferation here. So the lumen has been largely narrowed. There's lots of lymphocyte. This is a lymphocyte predominant infiltrate. There can be interruption to the internal elastic lamina, as well as giant cells. And these are the features that your pathologists are going to be looking for. Now, what is the utility for biopsy? Get rid of my laser pointer. So the sensitivity is not amazing. So it ranges from about 40 to 75% on studies. Specificity is high. It's not 100%, but certainly it is about as confirmatory a test as we can get. Now, as mentioned, only about 50% of GCA patients with large vessel disease are going to have a positive biopsy. So that's certainly not helping. The pros, it can differentiate mimics, things like encapsulitis, amyloidosis. It has high specificity. Cons, often can be a delay with procedure. I've worked a lot with the vascular surgeons at VGH. They're really good about seeing folks right away, but even just getting the report back can sometimes be a delay. And it is invasive, so things that we can run into, hematoma. There was a study that looked at temporal artery biopsies, and about 10% had some brow weakness at 6 months that improved to 3% at a year. So it's not a benign treatment, but certainly still has some role. Now, how urgent is it to get these biopsies in a timely fashion onto treatment? I'm not sure if you have yet, but at some point you'll likely have pushback from surgery that they've been on prednisone too long. There's no utility in a biopsy managed based on clinical suspicion. This kind of debunks that. So positive biopsies at baseline, they randomized to repeat biopsy on the contralateral side, 3, 6, 9, and 12 months. Quite significant positive rates, even going out to 12 months. Now, there can be some change in terms of the consistency. So we lose some of that giant cell and the acute infiltrate, but a lot of that remodeling can be present. So all that to say, even if they've been on treatment for some time, if you feel there's an indication for a biopsy, it still has some utility. How utile is it? What is the utility? So this was a study looking at about 130 biopsies and basically saw how it impacted treatment. 17 of those 130 were positive. They were continued on prednisone. 10 were insufficient, incomplete samples. They were also continued on prednisone. Of the 100 out of 130 biopsies that were negative, 90 of those continued on prednisone. So it is not a great rule-out test based on that sensitivity. And so certainly it raises the desire and the utility of improved sensitivity screening tests. So that takes us to imaging. So first-line imaging as of the 2018 EULAR criteria is ultrasound of both temporal and the axillary arteries. Second for cranial include PET and MRI. And extracranial, there's utility for ultrasound, PET, MRI, and CTA. Now, cranial MRI, highly sensitive. So if it's positive, definitely it's a good screening tool. Some of the cons, it's pricey, I should say. Time, so it's a long exam often. There's limited availability of 3 Tesla MRIs, which are needed to appropriately see these vessel walls. And it is quite sensitive to prednisone. So we lose sensitivity after about 4 days. And so it can be quite a challenge getting an MRI in due time. Now, PET, also highly sensitive. It also screens for some of our differential, including infection and malignancy. Some of the cons, also very pricey. There's a significant amount of radiation associated. Availability. So the BCCA will work with us at the vasculitis group in terms of getting PET scans for screening for vasculitis, but it can be very challenging. And certainly, given there's a time-sensitive nature, you could be hard-pressed at times getting a PET scan in less than a week. So that takes us to ultrasound, and this has been a major advance, essentially, in GCA management. Since 1997, kind of this landmark paper characterizing this halo sign, which we're looking at a transverse view of a cranial artery. You can see the central lumen and then this hypoechoic ring around it. That's the swollen, inflamed intima media complex of the vessel. And so that halo sign was kind of the landmark, and then things like compression sign, stenosis of the vessel, or even occlusion. And then we can also see thickening of the vessel walls extracranially. It is highly sensitive and specific. And basically, this sensitivity just keeps going up. And so we're getting better ultrasound machines. We're getting better at using it. And when they kind of limited, this was based on 17 studies in their review, it increased up to 93% when they kind of got rid of some when they only did prospective low risk of bias studies. So all that to say, ultrasound is really improving our sensitivity to catch this condition. What are we actually doing during an ultrasound assessment? So here's our 24 megahertz probe, and we're looking through the different layers of the vessel wall. That correlates to this image, and this is the lumen lighting up on our Doppler box. And if we zoom in, this layer of the vessel wall here, that's the intima media complex, and that's where the inflammatory process is actually taking place in GCA. Let's get to the vasculitic artery so you can appreciate that intimal proliferation. Now, when we're scanning that vessel, you can appreciate there's this hypoechoic thickening of the vessel wall. And if we get rid of the Doppler, this measurement, it's a very sensitive tool. And after you've looked at many of these arteries, you really do develop an eye for not only kind of this more diffuse, homogeneous, hypoechoic rim, but you lose kind of those layers of the well stratified layers of the IMT. Other features, so this image on the left is uncompressed, on the right is a compressed vessel, and you can appreciate at the lower vasculitic artery, it's just not as compressible, and that's a reflection of being more inflammatory infiltrate. There's more white blood cells, more fluid in the vessel wall, and that's just not going to compress as easily. And so this really does highlight kind of the ability for dynamic testing on ultrasound, which you can't really get with other imaging modalities. Where are we scanning? So these are all vasculitic arteries. We're looking at the common temporal, the frontal branch, the parietal branch of the temporal, and the facial artery, and doing both sides. And for large vessel, we're going to look at the axillary arteries, the subclavian, the carotids, and try to get a window for the vertebrals. Now, this is the beautiful Apteo i800. It's non-invasive. It's high resolution. It's more cost effective than kind of conventional workup. Dynamic assessments, some of the limitations. So we can't readily appreciate the entirety of the thoracic aorta. You can get some aortic arch, and based on habitus, go right to kind of the insertion of some of the major branches. But definitely there's areas we can't see. And so if there's high enough suspicion, that's where our CT angiogram comes in, or MRA. And this also loses some sensitivity with time on steroid, which kind of highlights our desire to see these patients quickly. It's about the 2-week mark is when we start losing significant sensitivity in the cranial vessels. That can be much more prolonged, and basically just with treatment, that vessel wall thickening that we see will normalize with time, but it's more time sensitive at the cranial vessels. So that takes us to our fast track clinics, and this is really kind of the model that is taking off, where we're trying to see these patients, very quickly, often within days of referral, and locally, we're trying to see these patients definitely within that 2-week mark. It's been demonstrated to show a marked reduction in permanent vision loss, so about a 90% relative risk reduction. Decreased inpatient days from about 3.5 to half a day. So definitely helps with our pleas for funding to help keep these patients out of hospital. And we're significantly reducing the need for temporal artery biopsy, but definitely it remains a tool for us, most definitely in those kind of indeterminate or borderline cases. Treatment. So just to highlight, we do not wait to treat to try to confirm with imaging. If we have a high enough index of suspicion, the potential morbidity associated with delayed treatment, we will give up the sensitivity to hopefully protect against stroke or vision loss. So don't wait to start treatment if you have a high enough suspicion. This is kind of a conventional steroid taper. So definitely there's been a movement across kind of rheumatology. We're trying to decrease the cumulative steroid for these patients. This is a fairly conventional taper, starting about 40 to 60 milligrams for about a month, decreasing by 10 milligrams to 20, then by 2.5 to 10, and then by a milligram kind of every month or so. That's kind of common thinking. We're now moving this up to about, most typically we'll start with Q2 week taper. And if that is a bit too aggressive, and we are commonly combining that with something like methotrexate to hopefully improve our success. But all that to say, we're trying to be a bit more aggressive in terms of our taper to hopefully save on some morbidity, given often these patients are older and will have concurrent diabetes, high blood pressure, cholesterol, many reasons that we'd like to have less than more steroid. Pulse steroid. So we most commonly use this for patients with visual symptoms or organ-threatening large vessel disease. The dose is commonly 500 to 1,000 milligrams IV. It's daily over 3 days. And then we'll typically start our prednisone taper from about 60 milligrams or less if they're less than 60 kilos themselves. Now, what's the evidence for pulse steroid? Not a great deal. There's 2 studies, one by Mazlamzadeh, which was a whopping 27 patients, and they got 3 days of close to a gram if they're 60 milligrams or 60 kilos, close to a gram of methylpred for 3 days, followed by a pred taper for 40 milligrams versus just pred taper alone. They did see a decrease in flares over 78 weeks, and they had more patients asymptomatic at low dose pred at 36 weeks. The other study was only one, about 250 milligram pulse, followed by a fairly conventional 40 to 60 milligram taper versus taper alone with prednisone. And this was 160 no significant difference in outcomes, cumulative glucocorticoid exposure, or adverse events, with the understanding this was a limited time frame. When it comes to vision loss, which is probably the most common kind of knee-jerk indication for when we're starting this treatment, there's no clear advantage to IV versus oral steroid in terms of preventing or recovering vision loss. What we have found is most likely more important is the timing. So Gonzalez-Gay looked at patients that had received steroid in under 24 hours versus those that had received it after 24 hours. And there was about 58% of patients improved within 24 hours of visual symptom onset, versus only that they improved if treated under 24 hours, and only about 6% saw any improvement if treated after 24 hours. And even on therapy, we're still in a somewhat risky period for about 5 days into treatment, which can occur in about 10% of patients, some ongoing or some further visual loss. And that risk drops to about 1% after 5 days. So just another point for starting treatment early if you have a reasonable index of suspicion for these patients. Steroid prophylaxis. So just about all these patients would be on 1,000 to 2,000 units of vitamin D, pantoprazole or alternative kind of GI protector for protection against GERD, and then calcium supplementation. So Health Canada, it's basically kind of as needed. I'll often refer patients to osteoporosis.ca to go to their calcium calculator and put in a typical diet for them. The target is about 1,200 milligrams per day, and whatever they're not getting in diet, we make up with supplementation. Septra. So there's no specific evidence in regards to starting Septra for all patients in GCA. We piggyback somewhat on some studies done in more rheumatic disease patients, which was predominantly inflammatory arthritis. But a couple studies by Park, essentially in the low prednisone dose group, and even in the moderate, 15 to 30, we're seeing quite low frequency of PJP. And even in the high risk group, which is kind of 30 or more, the hazard ratio is 0.2 with Septra on board. So it definitely is protective, but the number needed to treat versus number needed to harm with serious adverse events is not so dramatic. And so I think that led us to look at who were higher risk, and that was the patients that received pulse steroid, as well as those with baseline lymphopenia. And so definitely those are the patients that we are more keen to start Septra. And then certainly things like baseline lung disease, recurrent pulmonary infections, most definitely those are patients that we would have on Septra as well. Bisphosphonates. So our patients, the mainstay of treatment is long-term prednisone. This criteria is going to apply for just about every one of our patients, but the rule of thumb is anyone that's going to be on prednisone greater than 7.5 for over 3 months should be on a bisphosphonate. Now you can get into kind of the algorithm. If they're lower risk or on a lower dose, we'll typically get a baseline DEXA scan. And if it's low risk, it buys you 1 to 3 years, and then we restart. But essentially these are high risk patients. The risk for bone density loss is most notable when we're on high doses at the initiation of treatment. So as I say, I have a very low threshold to start bisphosphonates early to help protect against that bone density loss. Aspirin. So a bit of a ongoing discussion. There was a Cochrane review in 2017 that basically said there's insufficient quality evidence to say that all patients with GCA should be on a baby aspirin. Now, that's not to say there's no evidence, but certainly it didn't meet their threshold. And so ACR's recommendation in 2021 is that aspirin is something that can be added in GCA patients with either critical or flow limiting involvement of, they limit it to vertebral or carotid arteries. And if they're already on aspirin, that they don't necessarily need to, or that we wouldn't recommend stopping treatment. We in Canada open this up to basically any kind of flow limiting stenosis, and even with ischemic symptoms. So things like jaw claudication, certainly any ophthalmologic symptoms or limb claudication, we have a low threshold to start it. So that gets us into our adjuvant therapies, with methotrexate being a major DMARD that we're going to be adding with prednisone. The evidence for it is based on 2 main studies, or 2 kind of reasonable quality and a few less so. Hoffman was the first one. They were looking at a max dose of 15 milligrams oral weekly of methotrexate with their prednisone taper, and seeing a reasonable improvement in terms of relapse rate over the course of a year. Our typical kind of therapeutic treatment dosages for methotrexate is from 15 milligrams to 25 milligrams, and the difference between PO and subcutaneous. So there's probably about a 30% improvement in terms of efficacy for subcutaneous methotrexate relative to oral. And so the fact that we saw some reasonable improvements at a suboptimal dose in a suboptimal, or at least a lower efficacy route of treatment leads us to believe that this is probably a more effective treatment than this fully reflects. And that's all the more demonstrated in Jover's study, where they were using a max of 10 milligrams, which reduced the relapse rate, 10 milligrams oral, which reduced the relapse rate from 85 to about 45 over 2 years, with a number needed to treat of 5, which is not so far off. We're going to be chatting about tocilizumab in a moment. That's pretty meaningful, as is a decrease in 1.3 grams of prednisone. That's also a very meaningful difference. So just to say, methotrexate, we use it a lot. It's probably the first agent that we're reaching for in terms of adjuvant therapy, because we think it has good efficacy. Leflunomide, also a good option as kind of an alternative or even an add-on to methotrexate. A few studies just kind of demonstrating that there is significant benefit with a reasonably low number needed to treat, reduction in glucocorticoid exposure, and potentially some increased efficacy in terms of getting to a low dose prednisone. So certainly leflunomide, another option. Azathioprine, not as successful in the studies that have been done for it. Essentially some very modest reduction in daily prednisone dose after about a year, with a very significant increase in adverse events, which was kind of re-demonstrated in a subsequent study. So azathioprine, not something we're reaching for regularly for GCA. Now, Gayacta, anybody with an upcoming rheumatology rotation, just read it, answer the one pimping question to just get your block out of the way. This was a big deal for rheumatology. Basically, it was looking at tocilizumab, which is an IL-6 inhibitor, which is one of our biologic class immunosuppressive agents. Basically, they compared different frequencies, so either weekly or Q2 week tocilizumab versus a couple different prednisone tapers, with the tocilizumab group having a rapid 26-week prednisone taper, which was quite aggressive, or at least for the time, and essentially saw higher remission rates in the tocilizumab group, as well as about a 50% reduction in prednisone. So this was very exciting for rheumatologists. We saw that weekly was more effective than Q2 week TOSI for relapsing disease. And when they've done their extension studies, they saw that weekly is better in terms of flare prevention as well as glucocorticoid exposure over that more prolonged period. So that got a lot of people excited, a lot of creative juices flowing in the research community, and they're looking at how far they can take this. So this Gusto study, and these are just purely proof of concept, just kind of people, like I say, getting excited. But this study, they did 3 days of 500 milligrams of IV pulse at time of diagnosis. They treated them with 1 IV dose of tocilizumab, and then basically had them on 52 weeks of weekly TOSI with no prednisone. So these guys got 1.5 grams of prednisone, total steroid. 18 patients, but 80% in remission at 24 weeks, with about 72% relapse-free after a year. So very interesting. The Topazio study took that a bit further. They got rid of the 1 IV infusion of tocilizumab, and this was in large vessel GCA patients, which, as you may recall, these are higher relapse rate patients and often associated with higher higher requirements for cumulative steroid. And they had about 55% relapse-free at 24 weeks, about 50% at 52. So just kind of some proof of concept, some interesting kind of next steps, just as to how far we could potentially take the steroid sparing, or how far can we reduce our steroid exposure in patients. Cyclophosphamide, so this is kind of our in reserve treatment that is for patients on high dose glucocorticoid after a prolonged period of conventional treatment. So high glucocorticoid dependency, or for severe or life-threatening disease. The Duboisson study was probably the highest quality, where they did monthly cyclophosphamide infusions with about a total of 5 grams with a prednisone taper. About 9 out of 15 were in remission at mean follow-up after several years. And on their associated literature review, about 85% of patients will respond to cyclophos, but still have about 20% relapse rate. Secukinumab, or Cosentyx, this is an IL-17 inhibitor. These are kind of emerging therapies. So this phase 2 study, Titan, looked at secukinumab versus placebo, and they saw some meaningful improvements in terms of remission rates at 28 weeks. And this has been forwarded into a phase 3 study that's ongoing. Hopefully will be done in the next couple of years, but very similar kind of structure to Guyacta, a few different dosages, an aggressive 26-week prednisone taper, and comparing that to placebo. So we will stay tuned, but definitely kind of encouraging initial results. Abatacept, which is an anti-CTLA4, it's basically kind of limiting T cell activation, which are kind of the main drivers of inflammation in GCA. Their initial study showed about a 50% relapse-free survival versus about 31% in the pred mono group, which was just barely positive. And they did have some longer remission. The most important thing is there was no adverse events in the abatacept group. So this is, the interest in it as a potentially safe option from an infection standpoint in particular, in terms of adding to hopefully get people off prednisone sooner than later. And there is another study ongoing, Abigart, that is just furthering this question, which hopefully will have some more information in the next couple of years. Baricitinib, this was one study just a couple of years ago, 15 patients. These were prednisone dependent after about 9 months, so certainly resistant conventional treatment. They were treated with a year of baricitinib and were rapidly tapered off their prednisone in the matter of kind of 4 to 5 months. 13 out of 14 achieved remission at a year, with one dropped out. I think he had severe thrombocytopenia, and there were certainly some significant adverse events. But it really didn't take off. What it did get people more interested in was another JAK inhibitor, which these are oral medications, daily medications, which is another point of interest. And that's led to the SELECT GCA, which is upadacitinib or Rinvoq, similar to Guyacta, having treatment with aggressive prednisone taper versus placebo and kind of a conventional year prednisone taper. And this was kind of the initial results were presented at EULAR this year. And basically they look very similar to Guyacta. So when we get the full results, this hopefully will present upadacitinib as another alternative agent. And one of the foibles or one of the limitations when it comes to tocilizumab is that because it's an IL-6 inhibitor, it makes our CRP and our ESR not reliable. And so we lose that monitoring tool, which is certainly in correlation with clinical symptoms, a useful tool for trying to get a sense of how we're doing and how active someone's inflammation is. So the prospect of having a different agent that leaves CRP on the table is definitely very interesting. So we'll stay tuned for this. And hopefully BC will pay for bringing Rinvoq and paying for it. That'd be very nice. Relapse management. So there's a high relapse rate in GCA, specifically with pred monotherapy, higher rates in women, large vessel disease as mentioned, and with our shorter prednisone tapers. A minor flare, more often we'll recommend that we just increase to the last dose the patient felt well, and that may constitute with a slowing of our prednisone taper or adding an additional agent like methotrexate, leflunomide, or even TOSI. Major flares, we may go up to right to 40 or even 60 milligrams, or if it's ocular symptoms, we may even pulse. And most definitely we'd be looking at adding an additional DMARD in the context of a major flare. Duration of treatment. So the ACR was incredibly helpful in mentioning there is no set duration of therapy established and that it should be guided by patients' values and preferences. So use that as you will. But essentially, as mentioned, we are moving to be more aggressive in terms of our prednisone taper, and we're trying to get people off of prednisone in about 9 to 12 months. And if we have added a concurrent DMARD, which I'm doing quite regularly, priority number 1, get them off of prednisone. If they've had an uncomplicated course clinically and they responded well to treatment, after about 3 months, if they're on, say, 25 milligrams of methotrexate, after about 3 months, I'm trying to drop them to 20. And after about another 3 to 6 months, I'm dropping them to 15. And if they're doing well after another 3 months, they're off. So I'm hopeful to get, everything going exactly to plan. Patients may be off of therapy in about 18 months. Dom?
At what point would you say from prednisone or tapering down, would you consider adding that up front?
Yeah, I'm very,
1 month, 2 months, 3 months.
Yeah, so I'm very commonly adding it up front. So it's not as time sensitive as prednisone is going to be doing the heavy lifting up front. And most definitely methotrexate takes about kind of a month to 2 months to really take effect. So it is a bit of an information overload, as you can imagine. Patients coming into my office being diagnosed with GCA and getting about 5 new medicines. So I'll often give them information on methotrexate up front, and then we'll have a discussion in kind of short-term follow-up. But I'm often starting this up front, and I'm definitely starting it in patients that are, say, older women, diabetics, hypertensives, definitely patients that have large vessel disease. I've got a really low threshold because I want to get patients off prednisone as soon as I can. But, there's also patients that may have more significant infection risk, or just be opposed to adding more therapies, in which case I'll definitely, it's not uncommon that I'll start with prednisone monotherapy, but I'm definitely using it upfront quite often. So with all of that overview in terms of why and how we're using the treatments that we're using, this is what we do with it. So initial treatment, as seen, we're starting prednisone up front, 40 to 60 milligrams. If ischemic symptoms, we're leaning more towards 60, or if they're greater than 60 kilograms, most definitely we're starting with 60. If there's ocular involvement or organ-threatening disease, certainly we are trying to do it as promptly as possible, but we're often using methylpred. And while there's a range, often if we are committing ourselves to methylprednisolone, we're using a full gram. And after that 3 days, we'll taper down to either 40 or 60 based on body weight, and kind of typically lay out that Q2 week taper, which again is a bit more aggressive, but we are trying to hope for the best and kind of prepare for the worst. And so from 60 or 40, we're decreasing by 10 milligrams every 2 weeks down to 20 milligrams. Then we slow down to 2.5 milligrams every 2 weeks down to 10, and then right down to 1 milligram per Q2 week interval until they're off. And so the 9-month tapering schedule, things going well, hopefully, 5 months of that, they're on 10 milligrams or less of prednisone. And at the bottom there, it just said that if they are having flare of symptoms at Q2 weeks, we have a low threshold to slow down to Q4 week. And certainly we'd be thinking about DMARD therapy as well. We're adding for everyone, vitamin D, calcium, PPI, and bisphosphonate, unless some few exceptions. Aspirin, if already on, or if critical or flow limiting disease or ischemic symptoms. And again, this is jaw claudication, visual symptoms, limb claudication, or if there's kind of high grade stenoses that we're seeing on our CT angiogram. And then Septra, definitely for our patients with baseline lung disease, recurrent pulmonary infections, and consider if patients are lymphopenic or got pulse steroid in front. Adjuvant therapy, methotrexate, probably the one I'm reaching for most, and fairly readily so, as mentioned. Adding upfront large vessel disease, relapsing disease, or severe relevant comorbidities. Leflunomide, reasonable alternative to methotrexate, or add on to methotrexate if they have kind of a low-grade flare. Tocilizumab, definitely I'm thinking more and more in relapsing disease or active disease despite methotrexate, leflunomide, or a combination. And then cyclophosphamide for those more severe patients or kind of incomplete response to kind of conventional treatment. Duration of treatment, trying to get them off of prednisone in 9 to 12 months. If on a DMARD, I'm looking at starting to taper that after about 3 to 6 months, and kind of 3 months, things going well. 6 months if it's been a bit of a rockier course to get there. Flare, so part of the reason there is such a disparity in terms of flare rates study to study is that we cannot agree on what a flare means. Some studies it is a bit of shoulder stiffness, others it is CRP greater than 30 and ocular symptoms. So we kind of break it into clinical imaging and lab findings, and the Dan Ennis method is to kind of look for 2 out of the 3 to avoid having too much of a knee jerk. And so either symptoms, imaging changes, so predominantly kind of new vessel wall change or new areas of uptake or new areas involvement, and then kind of our CRP elevation or kind of thrombocytopenia, hyperferritinemia. 2 out of 3, we're most likely looking at having some augmentation. And then the treatment for flare is going to be either increasing the last effective dose, adding a CS DMARD, or if more severe, even going up to kind of 40 to 60 or even pulse. So the take-home points for this update in GCA, GCA is a multifaceted disease. There's lots of ways it can present. I was just chatting with Dr. Casson. We've got a very low threshold to scan people because we are constantly surprised. And so keep this in the back of your head. Most definitely, there's the textbook cases, but even that CRP, NYD, constitutional symptoms, no localizing features, just keep it in mind, okay? Vascular ultrasound has an established and expanding role in GCA diagnosis and management. Prompt assessment and treatment is key to preventing complications, and ongoing research is required to further refine induction and maintenance therapies. So that's the end of my talk. I'll just thank kind of the vasculitis group, Dr. Dan Ennis, Natasha Dagon, Corey Baldwin, Mo Barty, and then Kam Shajania, Dr. Avinia and Dr. Krani for all their support. It's greatly appreciated, but I'll open it up to questions.
Any questions, Dr. Hahn?
So I know like the guidelines, like if you're going through the diagnostic criteria for clinical and then also imaging plus biopsy, it uses a point system, but then the strict cutoff is that the age has to be greater than 50. I may have missed this, but do we ever see it in people presenting less than 50 years of age?
Yeah, not really. So as mentioned, so there are like very few instances where an individual, it's not going to be much younger. Maybe it'll be like 48, 49. There's very select instances where they may have compelling vasculitic features that we are convinced is not Takayasu's. I didn't go into this, but that 2022 criteria, they released both GCA and Takayasu criteria, and GCA's kind of absolute cutoff is for 50 and up, and Takayasu's is for 60 and below. So there's a little bit of wiggle room, but even if I'm seeing patients in their 50s, I'm squinting. I am suspicious that it may be something else, but 50 is I would keep in mind a fairly good rule of thumb, as we're unlikely to see GCA under that.
So if we order temporal artery ultrasound to radiology, will they automatically do the facial and the other vessels that you recommended, or do we have to specify all of those things?
Yeah, so
for rule out giant cell arteritis.
I apologize, I didn't highlight this as we were going through, but part of the really salient part of those EULAR recommendations for ultrasound being first line is that is contingent on the adequate equipment and training that goes into doing this. These are not scans that we are grabbing our ultrasound machines on 7D or whatever and going and putting on people's heads. It takes a lot of time just to see vessels, see enough normal. Like typically we'll recommend in terms of our training, we'll try to do 50 normal scans just to get a sense of what is out there. Because as mentioned, so many of our patients are going to be having, not only are going to be in 80s, their 90s, but they'll have dyslipidemia, and very commonly we'll see cholesterol mediated thickening of these vessels, which will look quite hyperechoic as opposed to the hypo, like the more black hypoechoic vessels. There'll be kind of these central hyperechoic white aspects to it. So all that to say, while I think there are ultrasound techs and some radiology departments that are doing some temporal artery scans, with the best of intentions, I give a bit of a discerning eye, as I'm not absolutely certain as to what the training they've had. So even locally, certainly if you wanted more large vessel scanning, I'm not sure that they would do that or if they've have the expertise. But I would have a low threshold, particularly if you're in the lower mainland, to just send a referral to Dr. Barty or myself, because we'll be seeing these patients quite quickly.
And then you do the scan on site?
Yeah, so I will have either at the Mary Pack across from VGH or at our clinic in Olympic Village. We bring the patients in and basically do the full scan of cranial and large vessel pretty much for everybody. Or if it's a quite low index of suspicion, they're at least getting cranials and axillary, as that's what brings our sensitivity quite high.
So then we might get a false sense of security then, as far as what the actual sensitivity of the scan was, depending on where it was done and who did it. We just see the report saying we didn't see anything.
Looks good. Yes, there's the possibility for false positive and possibility for false negative, which is very much the case for Dr. Barty and myself. But I think one thing we are trying to improve upon is just the more people that are doing these scans, the more capacity we have to train. And so hopefully locally, we'll just have more and more people that have gone through kind of the full training dedicated for this. And so hopefully just have all the more availability.
So just to highlight that, I think it would be incorrect to send the patient to ultrasound. I think that if you're concerned that you need to take it to somebody who's actually has this as their expertise. I think a normal ultrasound would be not very helpful.
Hello,
Sorry.
can you hear me?
Yeah.
Oh, yes.
You mentioned dental pain and mouth discomfort as in the differential, but can this not be a presenting symptom?
Most definitely. So yeah, we definitely see kind of maxillary pain, tongue pain, pain through the jaw. Natasha Dagon said there's no classic GCA case because it is so variable. And so I've seen every mix and some that have definitively not been GCA and some that have wound up being GCA. I would say that what I'm most looking for in terms of some of the more sensitive qualities of jaw pain is the claudication pattern. And this is not, while it can be, that is less common, kind of that first bite or jaw opening. It is more commonly going to be that pain at the jaw that's associated with prolonged chewing. So when you're increasing the oxygen demands at those muscles of mastication and those blood vessels, and mainly the facial artery is narrowed to the point that we're just not getting that necessary blood flow, that's when we're typically seeing the pain. And that's, I would say, the most characteristic pattern of jaw pain. But I will give the very, most definitely give the caveat that we see atypical cases, and not having that exact pattern does not mean it may not be related to GCA.
So
And as a follow-up, I've never met a dentist who's ever heard of this.
Okay.
Yeah, I mean, I haven't taken a poll recently, but most definitely we're commonly sending people to chat to their dentist. And it's kind of, a bit of I can't say I've ever seen a dentist note, and some of it I've never looked for it or asked for it. But it would be nice to have more of a dialogue between dentists, because I've started patients on treatment that had a dental infection that they felt better briefly on prednisone, and then we stopped prednisone and it was like, oh, my tooth is exploding, and we treated that. So definitely they are useful allies in our workup and diagnosis, but there can be some limitations in terms of our communication.
So I'm your secretary, and you're asking me to make appointments for people, and I'm only accepting appointments for people over the age of 50. And you're going to see these patients within 2 weeks. Can you give me some understanding of, as a secretary, how I'm going to decide which group of who you're going to see? So anybody who has a fever, anybody who has PMR, anybody. So I guess what I'm asking is, are there other criteria besides the clinical criteria? So and age, is there a time of the year? Is there a patient population, an ethnic group?
Yeah, all great questions. So essentially, thankfully, despite having excellent MOAs, they're not necessarily responsible for triage. So I will be reading this and deciding who to see. But as I mentioned, I have a fairly low threshold for seeing patients because I am constantly surprised, and GCA can be a enigmatic entity. But most definitely, there is a seasonal predominance. So of interest, we see more GCA cases in the fall and spring, which correlates with flu season. And so we didn't dig in too much into the pathogenesis, but there is kind of this hanging question as to the impact of viral exposures in terms of triggering not only GCA, but some of our other kind of autoimmune phenomena. So definitely, we are seeing many, many cases in the fall. Presently, we have kind of a wall of queried GCA because we do see more cases in the fall and spring. Other potential predisposing factors. So with Janet Pope's study, and when we looked at kind of Northern European, Scandinavian versus elsewhere in terms of epidemiologic studies, this is most common in individuals of Northern European or Scandinavian descent. So definitely those are patients that we are all the more so on the lookout for. Age, most definitely a risk factor for developing GCA, with the average onset about 70 or 74, I should say. And with the understanding that there's less 80-year-olds than there are 60-year-olds, to bring that down, or to bring that up, I should say. So older patients, Northern European, fall and spring. These are things that definitely weigh into our assessment. But I don't think I would turn anybody away for not meeting those criteria. Those all just kind of go into the gestalt we develop.
Thank you. I'll take the job.
Perfect.
Any other comments or questions? Yes.
Just wondering about follow-up, long-term follow-up, and whether there's a recurrence and those who completed their treatment.
Yeah. No, totally. So GCA is a condition that likes to flare, and most definitely early on and over the course of their treatment, it is very common that we'll see symptom recurrence or CRP elevation. And so even with a gradual conservative taper, once we've withdrawn treatment, there is the risk that it will recur. So definitely we're following these patients fairly regularly, even after they're off their immunosuppression, and perhaps even all the more so after they're off their immunosuppression. The longer time goes by without any sort of recurrence, the more reassured we are. And there's kind of a rough estimate, maybe at kind of the 5-year mark, the risk of having recurrence of GCA is quite low, but definitely we're always on the lookout for it. And definitely, we are all the more hopeful to kind of enhance that deep remission, which is another kind of argument for having our CS DMARD additional support for even once we're off of prednisone, to try to prolong that period and kind of gently wean off immunosuppression. But yes, we're watching for sure after they're off of treatment, but we are increasingly comfortable the longer the time goes by.
Any other comments? Yes, sorry.
Maybe we'll talk about the ultrasound earlier, but just that's sort of gold standard right now. And you talked about how you need a lot of exposure to doing the ultrasound in order for it to be the test to conduct. What is the training process for that right now? Are there a lot more people being trained? And how many do you need to see in a year to maintain that skill? Like, can you train more rural people and have that maintain that skill?
Yeah.
To serve those populations?
Yeah, great question. And at this point, no, we don't have the capacity. Dr. Barty trained me. He trained Ray Chu in Ottawa. And there is 2 rheumatologists in Calgary that are just starting. They just got their machine. There is 1 in Montreal and 1 in Toronto the one in Toronto is also quite early on. So it's about a handful in Canada doing this. And so we're going to be training Gary Zhu, the famous Gary Zhu, starting in January. And basically the training program, so we're actually quite fortunate. It's kind of a unique situation, and not unique, but definitely fortuitous for us in Vancouver, that because we are such a kind of concentrated epicenter of GCA scanning, we see a lot of cases. And so we saw 21 query GCA cases last week between Dr. Barty and I, more Dr. Barty than me. But essentially we're seeing lots of volume. And so between my training, I basically did my fellowship over the course of last year, which was a mix of musculoskeletal and vascular ultrasound. But between October and the end of March, I saw about 90 query GCA, like clinical cases. And I saw about 40, like part of my training, we kind of made this project to scan a bunch of normal individuals to kind of, given there's impact of things like age, cardiovascular risk, gender on baseline thickness of those vessels, we're trying to get a sense of how meaningful that is across some of our vessels of interest. And so basically there's an excuse to scan a bunch of normals. And so I did probably another 50 normal scans from last summer through to March. So that was about 150. At the end of 150, I felt like I knew what I was looking at, but I've learned a ton in the last 5 months of being an adult, and I'm continuing to learn. So definitely we are very fortunate here in Vancouver. We have tons of volume. There's lots of opportunity to learn. There's limited capacity to teach, but hopefully we're going to have more and more of us that are able to teach. But But in a rural setting, you're totally right. Like it'd be very challenging to have the volume necessary, or even in Prince George, it'd be very challenging to have the volume necessary to get that number of cases, which is a limitation for certain. And we're seeing patients not uncommonly that are flying down from all over the province just for that reason. Is we are for now the only shop in town, but it is 2024 and we're getting more and more people doing this. And so hopefully our capacity will expand and expand. But yeah, definitely a challenge for a rural rheumatologist that's interested or